Now, the visible start of this AIDS epidemic was in a very rich country, United States, and it was made known to the world in 81, 5th of June, by a very tiny little publication from the Disease Control Center in Washington, who talked about 5 patients who were all gay men, active young gay men, who had a very rare lung infection, which the doctors didn't know how to treat, and they gave a very rare medication, and that's how we discovered. So this is a very big victory of the American public health system, because they discovered AIDS, which was running already around the world, but we didn't know, because they noticed in their statistics that a certain medication, which is used very rarely in a very rare lung infection, was prescribed in Los Angeles very often in the early months of 81. And they contacted the doctors and wanted to know why they prescribed this. And what came out of this inquiry, behind there were 5 patients, 5 they had in common to be gay men, and they had all sorts of terrible affections, and the doctors didn't quite understand, and the lung infection was sort of life-threatened, and that's why they gave this medication. And this is how AIDS was discovered. Now, in June, or 1 month, the same month, a doctor in Paris was reading this little article, and he said, "Oh, I saw a patient this morning who had exactly the same symptoms, and I didn't understand." So he called the patient to come back. And this patient was the first case we had in Europe recognized. So you see, public scientific communication and journals are important. So we discovered the first case in Paris because one of these doctors was reading this journal. By the end of 81, in December, we had found in America and in Europe the first intravenous drug users with AIDS, hemophiliacs with AIDS, and Haitians, people from Haiti. Now, why these people from Haiti? Because Haiti is a wonderful island, and it used to be in those days, in the 70s and 80s and 60s, a holiday resort, particularly loved by the American homosexual communities who spent their holidays there. And there was a lot, of course, of prostitution going on with young men and young girls. And this is how, in fact, the AIDS came from Africa and arrived in Haiti. And because all these gay men had a sort of free sexual life there for the holidays, they transported it to New York and San Francisco. I don't have time to tell you all the story about this diffusion of AIDS. It's very interesting, but you have books about it, so you can read it. By end of 81, we counted worldwide 270 cases of AIDS, of which 120 had already died the same year. So this is a mortality of about 50% in only 5 months. And we had to wait sort of 1 year to discover the virus. There was a fight about between America and Paris, who discovered it first. It turned finally out it was a French team. So they got a Nobel Prize a few years later for this. Anyway, once the Pasteur Institute in Paris isolated the virus, they could very quickly make a test. So we had a test to see, a blood test, whether somebody had this virus or not. It was licensed, this test, in 85, very quickly later, and then started mass production. So this was very important to have a tool, a technical tool, to be able to see who had AIDS. And then we could also work on the transmission ways and invent a policy for prevention. So let's see 2 decades later. So I was talking about 81. Now we arrive in the early years of 2000. Something important happened in Africa, in South Africa, in those years. They changed the regime. Apartheid was finished, and Nelson Mandela became the president of South Africa. And we had at the United Nations, we had a general director who was also from Africa. And Africa turned out by 2000 to be a continent heavily touched by AIDS, and it was causing lots of death, lots of orphans, a lot of problems, social problems, because many people died and families lost their fathers and mothers and so on. So anyway, the United Nations with these two Africans collaborating, especially South Africa discovered that its Black population was heavily suffering from AIDS, much more than the white population. So the United Nations followed the AIDS problem and launched very serious alarms from 2000 onwards, saying there was a problem of international security because of this epidemic, because infected UN peace corpses came back to their countries being affected by AIDS, those who had been working in Africa, because there were lots of civil wars, and the UN sent peace corps. And then the countries didn't want to send their soldiers anymore on these peace corpses because they didn't want them to come back with AIDS. Scientific people worked out that populations who are weakened by an epidemic, more people die, are ill, they are weak, they can't defend their country, and then there's a risk of invasion from enemy countries. Armies get out of control when the soldiers are ill and know they will die. They may be particularly aggressive to civil populations and get into things, aggressing women and so on. So this was an alarm cry from the United Nations. And then came the non-governmental organizations who insisted on the human disaster, all the suffering, all the death people, all the orphans in African villages. There were villages where nearly all the adults had died and the children were left with the grandparents only, and nobody was there to work the land to produce the food. So the Food and Agricultural Organization of the United Nations calculated there was a risk of famine, especially in Africa, but also in other countries heavily concerned by AIDS, and of violent revolts for hunger, because the producers of the food were dying of AIDS or were ill, couldn't work anymore. So this sounds funny to our ears, but just think about what we know from Ukraine now, that they can't deliver their exports of wheat, and there is a risk of hunger in certain countries in the world in a few months. So this was very much the same that happened at United Nations level and the level of global health around the year 2000, 2004. The World Bank came in with there's a risk for development. If a population is in bad health, if population health is very low, then there will be a sharp decline in GDP and the development is at risk. So the result of all this alarm coming from the United Nations in those years was a big involvement of the United Nations. In 2001, for instance, the Security Council, who normally discussed wars, had a meeting for several days on AIDS. That was the first time in history that the Security Council discussed a public health issue. And the National Assembly of that year was on the subject of AIDS and what should be done. So these dates are not just by incidents, by accident, because just a few years earlier, in 96, 97, we discovered a very efficient treatment against AIDS, the famous HART treatment, highly efficient antiretroviral medicine, that's the word. So, but it was available only in rich countries, not in the poor countries. So these United Nations and the two African leaders, they wanted this to be available for the continent who most needed it, but there was no money and it was very expensive. So the South African government decided in 2000, it made a law saying that every person suffering from AIDS would get free treatment, and they were buying generic copies of this treatment from India and Brazil, who had the capacity to produce it. But the pharmaceutical firms who had the patents on this on these products, they went to the law court in South Africa against the government to say this law has to be abolished because it's against our rights as patent holders. It's against our interest. So, but facing this worldwide mobilization with the United Nations, all the ONGs, all the organizations from the United Nations, including the World Bank, the European Union, the French doctors, everybody was shouting against these pharmaceutical companies, and they finally in April 2001, withdraw their lawsuit, and a huge international coordination started to think about how can we make accessible this treatment to everybody worldwide. And that was the creation of the fund for AIDS, malaria, and tuberculosis to furnish basic medicines for these three illnesses. And it was financed by all sorts of channels, basically from the richer countries and also from foundations. And today this treatment is distributed, is much cheaper, and it's distributed worldwide to nearly all the AIDS sufferers. So this was a big pandemic, and what came out of it was quite positive. Now we have this idea that we can provide to the whole world without payment, if the countries don't have money, important medicine. So AIDS was a precedent for this. So this policy challenges, we come back to our countries, be it India or Europe. Once you have an epidemic like AIDS, which you don't know what to do, it didn't exist before, you have to do things immediately, and it's all very complicated. It's about very bad morals, it's bad subjects like sex. So there's no solution ready which you could apply. So in political science, we call such a problem an ill-structured problem. The problem doesn't fit our institutions. So this is a concept that was invented in 1973 for some technical problem in technology policies. And this man, Simon, he invented this concept, an ill-structured problem. So I think AIDS was an ill-structured problem for all the governments. Ill-structured problems means the known solutions and procedures are not adequate to solve this problem. What is needed is new problem framing, new ways, and that generally entails multiple resistance and controversy. So it's very difficult. Now, I sent you to a book edited by Kerp and Bayer on about 10 country stories about how they managed AIDS, 10 developed countries, so from the US to Japan and Europe. And they confronted two approaches to AIDS, which fieldwork showed these different countries. So there was fighting about how to control AIDS. There was an approach they called control and contain. That means you take the ancient laws you have in each country about how to fight epidemics or infectious disease or sexually transmittable disease. You isolate the people. If you have, you put them in hospitals. If you have treatment, you may oblige them to take the treatment. And so you would control the epidemic and contain the virus, and that means containing somehow the patients. And there was another approach, much more democratic, which I called participatory approach. It means you don't worry about these ancient laws. You take the people who know about the illness, that means the patients and their representatives. In this case, it meant the gay men, and specialists, public health specialists, and clinical doctors, and you work out solutions, very practical ones. And you need the participation of the concerned people and their representatives, because they know what they are doing and what is risky in their doings. So they are needed there, for two things: in order to sort out the risk, and secondly, in order for the prevention campaign to use the right communication, the right language. I have been sitting, when I studied AIDS, in many congresses for social science specialists on AIDS, and half of the people who worked on it were homosexual colleagues. And I can tell you, I learned a lot of vocabulary which I didn't know before, because it's the language of their community for them. And if you want to make a prevention and talk to the people, you will have to use their language, which a health minister in the government probably doesn't know. So you need participation in order to put up a proper, effective prevention. So this is quite, all the things I wrote in red here means this is a new approach, a new problem framing and new ways. Takes a participatory approach, and it led to, finally, this is what was done. And it started in Europe and in the US, and then it was exported to other countries. It meant a new public health approach, which respects the individual patient or the individual, simply individual person. It's built on participation, so these people who are concerned are policy partners, and on policy learning. You don't just take the old ways you always use, you will look for new ways. And you will learn them by participation, and you will by the respect of the individual patient. So it means stopping taboos, social control, isolation, discrimination, which was somehow inherent in those old laws. And it meant it was decided not to apply the laws on infectious diseases, on sexual transmittable diseases, on epidemics, on AIDS. AIDS was taken out of the list, or it was not put on the list of these illnesses which are under these laws. These laws still exist, but AIDS was taken out of the list where it should be applied to. So this is why I told you there was a difference between transmittable disease and infectious disease. Because AIDS was not infectious, there was no reason to have it on that list. You could teach people to have sex without transmitting viruses, take a condom, for instance. You can teach people who absolutely need to have intravenous drug abuse, but they can take a clean needle. They don't, teach them not to share their needles. So this non-application of those existing laws to AIDS was a big victory for this participatory approach. And you can see this was policy learning, and it was effective. AIDS is not the main public health problem today anymore worldwide. So the policy process, how we did manage. So if you take, let's say 10 countries or 15, and you look how they manage the AIDS problem in the US, in Europe, you have the period, you have basically 4 periods with different policy, with different issues and different actors. So you have a timing which treats different issues with different people at a certain moment. You have 81 to 84, which is a period of problem recognition. You have first to know what's the problem, what's the origin. Oh, it's a virus. Then you have to isolate the virus. Or you have to have a test, and you can see the transmission ways. And you can see and test people and see how widely spread the disease is. Is it a pandemic, or is it just a few isolated cases? So this was sorted out in those 3 years because we had discovered the virus and we had a test. So this period was then closed, and the year 85 arrived. Those, if you have people in your class who are old enough to remember that year, they will remember lots of protest and discussion and controversy, very violent ones, about how to use the test. There was a lot of political debate about how to use the antibody test. Should it be people who choose to have a test because they want to know? Or should it be imposed on all people to find out who has the virus and then isolate the people or whatever? That was a big discussion, but it was just a few months. It was violent, the discussion, but it was not very long because very quickly one understood that we have to follow the new public health approach, the participatory approach. So that means leaving a lot of freedom to individual people to have a test or not a test, and then see, what to do. So then followed a period 86 to 94, let's say. Once we knew what it was, the problem, and we had a test, and we decided we will make prevention campaigns and we will have a democratic approach to AIDS, we had to make public prevention campaigns. But what messages and for whom? Should there be for the whole population, always the same messages? Or should there be for risk groups, specific messages for the drug abusers, for the homosexuals, for hemophiliacs who can be contaminated by medical treatment? So there was a lot of talk about these campaigns, because some countries made very hard campaigns. Britain, for instance, they had the first campaign, it was just graves, lots of graves. And it was written, if you don't use a condom, you will end up on a cemetery. Basically, it was that. So the French had very soft campaigns. They made nice pictures with condoms jumping around, dancing. And then the title was, condoms wish you happy holidays, or with condoms you are free, meaning free sex. So countries had very different messages. But the main problem was, should the message be for everybody? So telling everybody has the same risk, everybody has to have a condom, or should it be targeted campaigns? So France opted for Republican values, for universal approach, everybody the same message, and it was a failure. They had to change their policy a few years later, because these general messages are not precise enough for the risk groups, are not precise enough to their problems. And for the general population, they're not believable, because it's not true that everybody has the same risk. It's not true that everybody needs all the time a condom. You know, a faithful wife or husband who hasn't seen anybody else doesn't need a condom if she's sure of her partner. So it was the wrong way, but this is very political. Countries have political ideas and cultures and do messages according to this, and then it turns out to be not the good way, and they have to change. So this was this period about public campaigns. So if you look at the actors here in the first period, you had the first specialist of the illness. That means the first doctors who cared for the first patients, the homosexual representatives, because they wanted to protect and help their ill people, and some public health officials, administrators who wanted to know whether this was an epidemic and what to do. So there were very few people, and they were the sort of managing the first period. Governments were not very interested in it. Well, bad subjects about sex and drug abuse, they don't like to talk about it. In the second period, you had all the political parties, left, right, fighting about what should be done with the test. You know, all the extremist parties and very conservative ones that wanted to test the whole population every 6 months. And then you had all the more democratic parties who thought this was not the best way, and it should be the individual decision and very democratic. And you should keep the medical secret. That was also an issue here. So this was a political phase, party controversies. This here was a period writing the campaigns. A lot of communication people came in, professionals, from journalists and professionals who make advertising, and television people, professionals of advertising mainly. And what they brought out was not always the best, because they did not always consider that making campaigns for public health is not the same thing than selling shoes or cars. Anyway, these were the three big periods of AIDS management. And then came a period which is still on, started with the mid and 890s, because we had a treatment, this hard treatment, highly active antiretroviral treatment. It came on the market in 97 and was very expensive, needed a little bit of time that the prices drop, and then it was made mass production really for the world. So this normalized the issue, because AIDS became just an illness which you can treat with pills. The problem you have just is universal access to the pills, that's all. So, and we had a lot of public health reforms in order to better manage the preventive part, after we had the scandal with contaminated blood, and the warnings and the terrible news about the worldwide extension of AIDS. So global health improved, and health reforms in developed countries for better public health, not only medical treatment. And then, of course, medical treatment was pushed up with this medicine. And we had a high level of international involvement, which from 2005 onwards worked to get all the people in the world under treatment. It took about 20 years, but now it's nearly achieved. So AIDS is sort of a normal problem now. It's not an ill-structured problem anymore, but it needed about 20, 25 years to shift from an ill-structured problem to a normalized problem. Now, the factors of policy success and failure, I could compare it from my own studies about different countries. A factor of success or failure is, first of all, the government action. Is it rapid or is it late? If it's late, you will have failure because an epidemic goes very quickly. If it's rapid, you may have a policy success. And if the messages you deliver, are they clear or unclear? Are they understandable by those who need to understand them? So these two issues we have also for COVID. You know, when they told us in the beginning, we didn't have masks in France especially, but in the whole of Europe. So the French government told us people should not wear masks because they would get infected with their masks, because they would not know how to put them on properly. But this was just an argument that people should not run about masks because we didn't have any masks. And the few masks there were, they should be kept for doctors and hospital people, workers. So it was a bad message. It was not a true message. It was the wrong one. It was just a sort of, you know, little lie. This is not very good for success. It's rather for failure. Yeah? Because when the masks were available, then people didn't want to put them on because they were told it was dangerous before. So clear messages, rapid intervention. That's the factor of success. And the policy style should, if possible, be consensual, because if it's conflictual, then the coherence of the policy and its implementation is at danger. So if there's a lot of controversy about whether you should get vaccinated or not, then people hesitate and don't get vaccinated. So if you have a consensual policy that all the parties say, oh yes, we should vaccinate all the people, that's good, then people go and get vaccinated and you are off for success. Because the legitimacy of the anti-AIDS or anti-COVID policy, the social acceptance will be higher if you have a consensual policy style. But that depends very much on the political culture in the country, whether people have a culture of always fighting and contradicting from their colleagues or the other parties, or whether they have rather a consensual style. A consensual style is very much typical for the north of Europe. The south is more conflicting. Institutional factors come in, the capacity to adapt, the capacity of institutions, public health institutions to adapt, and the capacity of professionals to learn new ways and do innovations if there is a new problem, ill-structured problem. So, and the coordination of medical care, social support, and legal provision. You know, people who had severe AIDS, especially in those earlier decades, and the treatment was not yet really available, they had lots of problems. They couldn't work anymore. They needed help, even at home. They couldn't go shopping anymore. They were suffering hell. So you needed medical care, social support, psychological support, legal provisions to protect them against, let's say, that the medical secret would be kept, that their insurances would not know, or their employer, that they have AIDS or the virus. So all this had to be coordinated. These are institutional factors. Some countries know to do this very well, others less. So this will determine success and failure. And cognitive references. So what are the values put forward? If you want to fight AIDS or COVID, will you say you have to do this, you have to put on condoms or masks because this is for public health, it's for you and also for your neighbor? Or will you tell people moral things, for instance, about sex, you know, keep abstinent and you won't have any problem. You say that instead of taking a condom. I remember President Bush Jr. in America, he changed the American AIDS policy for Africa, the development policy. And he said, you will only get money to fight AIDS if you make prevention on abstinence. Before they made prevention, they wanted prevention on just condoms, you know. So moral discipline is generally not such a good, effective message. It depends on the issues, but the best is you take the pragmatic way and talk about public health, and people can understand that. So, and then there's a problem of do you have in your political culture an intermediate field, which is at the same time public and private life? In Europe, we have two major religions, Protestants and Catholics. And the religious wars we fought in history between Protestants and Catholics, they obliged the North and continental Europe to make peace between these two communities and accept that there are things which are in one way public, like religion. You know, people go to church together, and then in schools you can teach or not about religion, but it is basically a private life issue. So, and sex education is the same. Sex is something public and it is something private. So in countries where you have a sort of political culture where there is a public space and a private space, but in the middle there is a space where there is something public and private both. And it means that the government is allowed to come in and tell you, well, this is private, your religion is private, but I don't want you to pray in the street, please pray at home or in your church. Or sex is private, but there's a public health issue, so please take a condom if you have outside fidel marriage sex. So there is something public in the private life issues. And if you have a political culture where you can treat this, then you can much easier pass messages about public health. Because sex, health, religion have this in common, that it is public dimension and private dimensions. So the government should be able to come in sometimes into this private issue, and people should be able to accept it. So as the Catholic Church had a tradition of wanting to govern the private life of people, especially their sexual life, they have much more problems with this intersection of public and private. So, and Southern Europe managed AIDS much less well than the north of Europe. And I think it comes back to authors like Max Weber, who insisted very much on the deeper cultural basis, which sometimes has religious roots, even if people don't believe in God anymore. This is culture and it remains. So this is what I wanted to say about the factors of policy success and failure. If we cut it short, the factors of success are very clearly government action, which is quick, consensual, and coordinated. Coordinate can also mean between the local governments and the national government. Yeah? And is oriented by public health expertise and goals, this government action. It respects citizens' right to privacy and to protection, to medical care, for instance. And it has efficient healthcare systems, which can serve the ill people for COVID, that you don't die because you can't breathe anymore and you have equipment, respirators for these people, or for AIDS, that you have the good heart treatment available. So this is broadly the success factors to fight epidemics. You need a good government action. So if you have bad government, you probably will go for failure.